Webinar is now streaming live on Facebook.
Yes, it is.
For me, the greatest role that HCMA has played is in education and communication, with the conferences and all the learning that occurs there, meeting other individuals and families and how they work through their HCM issues.
I'm glad that I got to meet with the disease that kept telling me what you're feeling today is normal and what you're feeling tomorrow is normal. It can be scary. I mean, you know, a whole bunch of emotions and thoughts go through your head, and some of those thoughts are not necessarily the best thoughts. But, you know, knowing that you're not the only person with this disease and that there's a whole village out there to support you with this is reassuring.
The people involved are wonderful. They're low key, they're nice, they'll help you with anything that you want. They'll give you information. I think that this is a very good venue to find people that can relate and that will enhance the exposure of being sick and finding help for it.
So I tap the HCMA all the time to see what other people experience, what the prevalence is of different situations, what our options are.
I spoke to Lisa Salberg on the phone. She said, send me all your medical.
There was a teaser, folks, of our upcoming website content as we're getting ready for our Bighearted Warrior Tour stop in Houston, Texas at Methodist. We have a wonderful faculty for you tonight, and that was just a little teaser. And during my talk, I might even give you guys a sneak peek of the brand new website that is going to be launched on June 16th. So welcome, everybody. We're streaming on Facebook. I have a couple of housekeeping announcements, and then I'm going to turn it over to Dr. Sherif Nagueh, who will introduce the staff that he has that is here. Number one, Facebook viewers, I have placed a link in the description. If you would like to join us here in the Zoom room, you can just log in. I'm breaking the rules. I'm circumventing the registration process tonight. You could just kind of jump in. We're going to see if that helps a few more of you find us. Because on Facebook, we're not going to be answering your questions. We will, however, be able to address them specifically in the Zoom room. So if you have questions, comments, please join us in the Zoom room and you can ask those questions. During the event, there is a question and answer box on the bottom for those who are in the room here with us and it's on Zoom. You can use that question and answer to post your questions throughout the day. Our faculty is welcome to answer them in writing, or we can wait until the breaks and then we can answer them live. If you're looking for a consult via webinar on your very specific question regarding your HCM, we can't do that here. Our purpose tonight is to provide education that is meant for the masses. We have wonderful physicians who you can contact privately to get those consults, but we can't get very deep into specific cases. What else do I have to tell everybody? This is being recorded. While we're streaming on Facebook, we will also be recording. This will air later on YouTube and be housed on the HCMA website eventually. But for now, you're being recorded. If you ask a verbal question or you identify yourself in any way in a chat on Facebook or in the chat box here. If you would like to ask a question and not be recorded, you must be in the Zoom room. Wait till the end of the webinar. When we stop streaming on Facebook, we'll stay there for a little while and answer any questions that somebody might not have wanted recorded for all posterity, because the internet lasts a really long time. So without any further ado, I will hand over my duties now to Dr. Sherif Nagueh, who will introduce you to his crew after I introduce you to mine, because I always forget that. With us tonight are HCMA Volunteer Coordinator Julie Russo, Julie give a wave, and HCMA Event Coordinator Amy Mann. And I thank them both for all of their amazing work, which is allowing me to go on vacation tomorrow morning, knowing that the HCMA is in good hands for a few days while I take some rest. Dr. Nagueh, it is your turn to tell us about your team.
Good evening for all those who are joining us, and thank you for joining us. And we thank Ms. Lisa and the Hypertrophic Cardiomyopathy Association for this opportunity to speak with you today. We here at Methodist DeBakey Heart and Vascular Center see a lot of patients and treat a lot of patients with hypertrophic cardiomyopathy. I want to introduce to you the team of physicians I'm honored to work with. I have my colleagues, Dr. Valderrabano, who is an electrophysiologist, Dr. John Buergler, who is an interventional cardiologist and the program co-director, and I have Dr. Gerald Lawrie, who's an esteemed surgeon with a lot of experience with this disease and treating successfully patients with this disease as well. We work as a team and we evaluate what is best for each patient. I have some information that we will be happy to share with you, each one of us, to give you different aspects of what you would go through when you go through our center. We're happy to take questions, and Ms. Lisa will help coordinate these. With that, I can start my presentation, and it will be about imaging in hypertrophic cardiomyopathy and its role in establishing the diagnosis. I'm going to share my screen now. I trust you are able to see my slides now.
Yes, we are. Thank you.
Before we get into imaging, I just have on this slide how you can reach us. This is our address. We have a dedicated phone that you can reach out to schedule appointments. We promptly see our referrals within the week. We have our contacts, be it by email, or if you want to mail us information, we are happy to answer these. And we see patients both virtually and in person in the clinic now. With that, I will delve into my presentation about imaging.
I'm going to go into presentation mode, and then I'm going to mute myself. This makes it a little easier to read.
Okay, I'll continue now.
Sherif, what I was saying is you're not in presentation mode on your PowerPoint.
Okay.
And switch your display settings.
So now I am in the presentation mode. Do you see it this way or not yet?
We see it, but we see the cheater version where you can see the next slide. So if you have two screens on your computer.
Yeah.
So do a display settings and switch your monitor up on the top.
Yeah.
Click that and swap the, there you go. I'm going to shut up now.
Okay. Okay, thank you. So we'll talk about imaging. Hypertrophic cardiomyopathy is really diagnosed by increased thickness of the heart muscle. That the scientific term for that is hypertrophy. And this is a cross section from the heart of the patient with hypertrophic cardiomyopathy. This is the thick left ventricle. This is the right ventricle. And if you look under the microscope, you see a lot of cells going in different directions. That is called disarray. And then you see a lot of fibrous tissue that stains red. I will show you that by imaging, we are able to see hypertrophy in exquisite detail, as well as fibrosis. And there is ongoing research aiming at better discerning of disarray. Mind you, this is a lot of achievement to be able to establish these observations without a biopsy of the heart. When we think of hypertrophic cardiomyopathy, we describe what the heart looks like. So morphologically, what does the heart look like? We have a pattern where the septum, that's the wall that separates the left from the right ventricle, is exceptionally thick. And very frequently, this goes all the way from the base to the apex in many patients. In some, the thickness is restricted to just the base of the septum. In another type of hypertrophic cardiomyopathy, I should say another morphology of hypertrophic cardiomyopathy, another shape, you see the apex being very thick. And in some situations, which is really rare, probably 5% or less, the heart is thick all around. That's the left atrium of the heart, and it gets enlarged in many cases, and that's the mitral valve. Let's look at what a normal heart looks like before we look at a diseased heart. And so that's what we call the aorta, that's the mitral valve, that's that septum you were seeing on the previous slides, and you see how thin it is, how thin the mitral valve, and that when it opens, it stays away from the septum. That's a short axis of the ventricle, and we see the thickness all around is about normal. Remember the short axis we saw in the pathology early on. There is nothing similar to that. That's a normal heart. Then we have views that show us more of that ventricle. That's the septum, that's the thin mitral valve. And you don't see anything wrong with that valve motion during systole. It's staying away from the septum. We are able to process the ultrasound signal and display the flow in different colors. And we see normal flow velocities. The blood is not moving fast through this area of the ventricle. We call it the outflow tract. We are also able to look at performance of different heart segments by a technique called strain, and we display it here. Nowadays, if you go to a hypertrophic cardiomyopathy center of excellence, you should be expecting to see these measurements performed and reported. Now let's look at the patterns of hypertrophy that we saw in the cartoon earlier. There is one where you can clearly see the septum exceptionally thick. Compare that to that wall of the heart. We call it posterior wall, or the behind, or the part away from the chest. See how thin that is compared to the very thick septum. That's the heart that is thick all around. And then that's the heart where the apex itself is very thick. All of this is muscle. Sometimes it's a challenge to see that apex of the heart, and we use what we call ultrasound enhancing agents. And then this shows the cavity very well and allows us to see the walls of the heart being very thick at the apex.
Hello.
Sometimes we have suboptimal images.
Good, I have a very...
Ron, you want to mute your microphone, please?
Sometimes we have suboptimal images and cardiac magnetic resonance is performed, and we can get images with excellent resolution with CMR, meaning we are able to see a lot of details. And this is an example from a patient where the septum is very thick. And again, if you remember that cut from the very first slide, we see the left ventricle here, the right ventricle here, and that's the septum being very thick. This is the apical hypertrophy that we saw by echo, a couple of slides. We saw it earlier in the cartoon, and you see how all that apex is filled with muscle. We are also able to see the same patterns by CMO, cardiac magnetic resonance, as we see them by echo. That's a case where the septum is thick. That's the apical hypertrophy we just looked at the movies of. There are few cases where cardiac magnetic resonance may not be feasible because they have had an ICD that was implanted years ago and would not be safe for the patient to undergo cardiac magnetic resonance. If there is still a question about the diagnosis or additional details of the ventricle need to be obtained, cardiac CT can then be performed. And that's an example where the septum is very thick. That's an example showing you how the septum thickness is measured, and it's here close to 20 millimeters. That's very thick. The normal thickness in men and women, it most of the time does not exceed 11, or if you want to stretch it, 12 millimeters. And there is the pattern of apical hypertrophy that we saw examples of as well. But most of the time, what we really need is echo and cardiac magnetic resonance. I want you to know that when you get an echo report or a cardiac magnetic resonance report, what should you look for and what do you care about? The report should mention the wall thickness. And the clinician has to put the report they get with what the patient has, what they presented with, because there are other reasons that cause the walls of the heart to be thick. It's not only hypertrophic cardiomyopathy. Another thing, the wall thickness, as it goes up, the chances of sudden cardiac death go up. And so how thick the wall is a factor that is considered when looking at the chances of an individual having a risk of sudden cardiac death. And nowadays, there are many treatments that can decrease the wall thickness. Sometimes these are invasive procedures and sometimes medications, as you may have heard. It is possible to track this wall thickness and measure it by the different techniques you saw today. We also care to look at the heart function. That's a measure of how much the heart is shortening. And if you look at the curves from a normal individual versus a patient who has hypertrophic cardiomyopathy, you see the performance is much worse in the hypertrophic cardiomyopathy patient, even though their ejection fraction can be preserved, and it's usually preserved. Let's talk about obstruction. If you recall the normal subject, the mitral valve was staying away from the septum. Here you see the valve touching the septum and causing obstruction. We put color and we see the acceleration of flow because blood is moving now with a very high velocity. There is also a leak of blood back into the left atrium, and that's the mitral regurgitation. We are able to look at the contact between the septum and the mitral valve with a technique we call M-mode that has excellent temporal resolution. And that's the picture of the valve touching the septum by echo and showing you the acceleration of blood like an inverted Y with its two legs here. One is the mitral regurg and one is the acceleration of flow. This is dynamic obstruction that you saw by echo, but now you see it by cardiac magnetic resonance. You see the leaflet of the mitral valve touching the septum, and that darkish appearing color called signal void is the mitral regurgitation going backward into the atrium. In some patients, obstruction is present at rest, but in many other patients, you need to provoke obstruction. And there are several methods that provoke obstruction. The one that is most reliable and that is used and recommended is the exercise. Sometimes patients have multiple reasons or may have other reasons for this obstruction. And before a physician recommends a procedure or even medical therapy, it is important to know what else may be going on. So example, some patients can have narrowing of the aortic valve. That's a look at the aortic valve, which should have 3 cusps, as you see here. This is the actual opening, and it is very small. So this patient has a problem with the aortic valve. Sometimes it's the only problem they have and why they have the symptoms. Sometimes this is present on top of hypertrophic cardiomyopathy. That's a patient who was born with this problem, and the arrow is pointing to a membrane in the outflow tract. This is a patient who would be referred to surgery if they have significant symptoms and obstruction for the surgeon to remove this membrane, and they would not go for a myectomy. That's why it's very important to look carefully at these pictures and examine the patient carefully. That's another case where a patient has a torn segment of his mitral valve, and you see here a lot of color in the chamber we call the left atrium, showing a bad or a large amount of leak. Again, this would be a surgical referral to repair the mitral valve and not necessarily be a myectomy. Sometimes they coexist, and then the surgeon would attend to both. Papillary muscles can cause problems by themselves, and they can be readily visualized by cardiac magnetic resonance, as you see here, where the papillary muscle is extending into the outflow tract. If that is causing obstruction, that's a target for the surgical approach. So why do we care about these findings? I hope we covered these items. We talked about how to detect them, the location. We can determine how severe the problem is. We can carefully select the patients for myectomy or mitral belt surgeries. We can refer patients appropriately if they have dynamic obstruction with hypertrophic cardiomyopathy and thick septum to medical treatment and septal reduction therapy. The last item I will cover is the tissue characterization. Again, if you go back to that very first slide and we look here at the pathology, you see this white lines marked by the arrows. That's fibrous tissue in the heart. Cardiac magnetic resonance allows you to see these scars really well, and you can see that they match nicely what the pathology shows in both cases. The more of this whitish appearing material throughout the heart, the worse the heart function and the greater the chances of rhythm problems. And they can be distributed in different areas, as you see here by the arrows in these different examples. This is from the case that has apical hypertrophy. Over time, the muscle died, got replaced by fibrous tissue that you see here filling the whole apex. That's the appearance of the normal muscle. So why is this important? It is important because in some patients, the echo findings and even the CMR findings, before you consider this tissue characterization aspect, can be borderline. But if you see scar patterns that are typical of those that are seen in patients with hypertrophic cardiomyopathy, this can help establish the diagnosis. Also, they are of value in deciding whether a patient has a high risk for sudden cardiac death, and they can inform the decision for implantable cardioverter defibrillator. So in summary, when we see a patient with hypertrophic cardiomyopathy, frequently the first test that we do is an echocardiogram. If there are suboptimal images or if additional details are needed, particularly about the papillary muscles, we will do a cardiac magnetic resonance test. We typically use injection of an agent called gadolinium so that we can see the fibrous tissue that we talked about. After patients get treated, echocardiography may be repeated, so you look at what happens to the gradient and the wall thickness as part of understanding how well they responded to the treatment. Thank you, and with that, I will stop sharing and give that back to Miss Lisa.
I will take it back.
So I click the stop sharing. Do
You
you
click the stop and I click the start because
okay.
We were very excited and I forgot that I have some things to say too. I didn't do my talk. So we started with you. That was an excellent presentation. So I'm going to do a stop share. That was just to remind me that I need to do that. If there are any questions from the audience, they can put them in the chat box now. We will be doing a global Q&A at the end. So if there was anything that you couldn't, you're still deciphering, you can ask those later. I do want to ask you a question to kind of start out the Q&A part of this. Strain. We haven't talked a lot about strain and why we do strain in these echoes, within HCM. Could you talk a little bit about the technology and what is strain and why is it important?
So strain is a measurement of the extent of deformation of the heart muscle. If you take any tissue and you apply force to it, that tissue gets deformed. The extent of deformation is strain. When the heart muscle has abnormal function, the strain measurement gets reduced. And so many patients with hypertrophic cardiomyopathy, I would say most patients with hypertrophic cardiomyopathy have a ejection fraction. I believe this is a term our audience are comfortable with, that looks normal or even hyperdynamic, meaning a number more than 70%. However, if you look at the muscle function itself, it is not normal. It can be reduced. And strain allows us to decipher the presence of reduced heart muscle function. Clinical studies have shown that hypertrophic cardiomyopathy patients who have reduced strain have a higher risk for heart failure later on, and they also have a higher risk for arrhythmic events later on, including sudden death. This is a field that is growing in terms of data accumulating. It hasn't made its way yet to the regular guidelines, so to speak, but it will be emphasized in the upcoming imaging guidelines. It's available on all of the routine ultrasound systems that are now present. So we're not talking about old machines. And most sonographers and labs that are, many of the labs that are accredited should be comfortable performing it. And therefore the physician looking at the study should include it in the report.
I can remember getting called into, I think it was AHA, and one of the imaging companies was trying to pull people into a session on this new technology called Strain. And of course it was like at the last room in the humongous conference center. And I'm like, I think there might be something to this. I'm going to take the walk. And the first time I heard about it was in this talk. I'm like, I think we're going to be able to use this at some point when we learn more about it. And it's really interesting to see that I'm going to guess it was 13 to 14 years ago. It was AHA.
You're correct.
Yeah. And we're here now, and we're talking about using that technology. It takes a long time to go from concept to practice. So I'm glad to see it being used more regularly. I am going to go back to do a quick talk just to update people on some things at the HCMA, and then we're going to hand it over, I guess, then next to Miguel.
Dr. Valderrabano.
Yeah. There's names that I tongue tie very easily. Hi, Miguel. We're going to keep it there. I'm going to do a quick talk here, and then I'm going to hand it back over to you because I have to do things like thank our sponsors. So, and tell them a couple things about the HCMA, and then we're going to bop back over to you guys. Okay, so number one, I'm using Google Slides for the first time because my PowerPoint failed. So this will be interesting. You know what we're all doing here tonight. Oh, let's see how this works. There we go. Big thank you out to our sponsors for tonight's event. Bristol Myers Squibb, formerly Myocardia, Invitae, Cytokinetics, and Boston Scientific. Without them, we can't bring you programs like this. And I do want to say that our sponsors and our partners are amazing, and we thank them so much for their support of this community. So here comes my joke of the 2021 genre of HCM. I truly believe that the 25 years ago that the HCMA was founded, we were the land of misfit toys. So we were the island of misfit toys. You remember that from the Santa Claus movie? We're actually Rudolph. So with all of these partners now coming up with novel medications and new treatments, and there's some exciting stuff coming up that you don't even know about yet. But now I feel like the cruise ship found the island of misfit toys, and they're all coming on board, and they all have amazing things that they want to offer. And there's going to be some amazing educational opportunities coming out for patients, for clinicians, for treating cardiologists and family practice docs. We've got a lot of stuff going on, and it's thanks to our sponsors who not only sponsor us, but other events going on in the HCM world. So yay, sponsors. This is tonight's presentation. We are going to be covering the treatment of arrhythmias. We're going to talk about alcohol septal ablation and septal myectomy. So the theme of the night from this point forward, other than arrhythmias, is septal reduction therapy. So that's all going to be handled later on. I do want to talk just for a moment about our Center of Excellence programming. We are now at, oh no, this is an old slide. See, Google Slides got me. As of today, we're at 42 programs in the nation, with a 43rd being presented to the board this week with a final decision due in 30 days. So it looks like we will be 43 by end of summer. So very happy about that. I'm going to just show my cute little HCMA hocomologist slide. Sherif, normally I put a picture in here. I've had such a crazy day. I didn't get to put your picture in here. So imagine Dr. Nagueh's picture here as the hocomologist, as the program director. Patients get put through this program. Ugh, Google Docs, man. Each of these little stick figures is supposed to land in a bucket for a period of time and then come back to the Center of Excellence coordinator to ensure that the care is staying consistent and that patients don't get lost in subspecialty care when they really belong back with their hocomologist. This concept was proven out after 20 years of us running these programs and developing these programs, the American College of Cardiology and the American Heart Association new guidelines came up to the same conclusion that comprehensive care models for HCM are the way to go. If you can't get a comprehensive program, then a primary, which may not have transplant or surgery, those things can be referred out, but you always need your primary cardiologist at home. We need that home-based cardiologist in case you run into problems at home. You need to have that connection point back. And if the Center of Excellence program is working with your local cardiologist in your care, that's the best of both worlds, because the doctor learns, you get good care, and you're in the hands of the experts. We know that this works. You've told us through surveys, thousands of you, that you feel better, that your quality of life is improved both physically and emotionally, that the outcome, we know that the outcomes from procedures have less complications, and you have the opportunity to participate in clinical trials. We know from the clinical data that outcomes are better. There have been meta-analysis looking at this. We know that patients are treated with the appropriate level of care, not overtreated, not undertreated, and that you're less likely to be on therapies that are inappropriate or contraindicated, or have testing that is inappropriate or contraindicated. So this is a new slide for tonight. I'm glad Google Docs helped me out here and didn't kill it. We have added a brand new, first of its kind discussion group as onto our social media page today on Facebook. We have added our HCMAI, first time anywhere this logo is being seen. HCMAI is our international outreach, and we have partnered with some patient advocates in Sweden, and we now have a Swedish language group. We will be adding an Italian language group in the coming months, and additional countries are coming on board. If you're not from the United States and English is not your primary language and you're passionate about HCM, you'll want to contact us, and we'll help you get your patients in your country organized and make sure that they get the best care possible in your nation. The online support group. Oh, there's the picture I was looking for. These are actually our online support group leaders or discussion group leaders. This week, the calendar is down because next week we're starting the new website. So the calendar will be fully populated for support groups from June 21st on. Sorry about the little pause in production here, but it's a little hard to register if we're going to be taking down the site. So we didn't want anybody to get lost in the process. So these will be back up line on the 21st. Tales from the Heart. There is no Tales from the Heart tomorrow because I'm on vacation, and I did Tales from the Heart today with Marty Marin, and we talked about exercise and competitive athletics. So if you want to go listen to that, it's on the Facebook page right now. It'll be on the podcast uploaded in the next 4 to 5 days. Our Legislative Advocacy Committee, get used to these logos. We have all new logos and stuff coming up. We are going to be launching our training program to start probably August this year. And our training program will help you learn how to be a legislative advocate and talk to your lawmakers about legislation that we're hoping to introduce to include the same components of a sports physical in terms of cardiac screening in all well child examinations. So this is a state-by-state initiative. If you have the willingness and the wanting to change laws to help us identify people earlier in the process, give us a call at the HCMA. Our volunteer coordinator, Julie, will be happy to start getting you signed up for these programs, which will be available shortly. If you haven't watched the patient-focused drug development meeting, which took place almost a year ago this month, it was the 26th, I encourage you to do so and visit the website for the Voice of the Patient report for the written version of what is important to you as a patient. And we're hoping that our FDA regulators have taken a good look at this as they are doing their evaluation of mavacamten and other novel drugs that are going to come down the pathway for HCM. So we're very excited about this meeting, and it's still very important, even though it was a year ago. Reminder that the Invitae genetic testing panel is still available free of charge to anybody with HCM and their family members. You can get that link from the website as well. And I want to take a moment tonight, and I'm going to show you something very important and very sentimental. June is a tough month for me. June is the month where I lost many of my family members due to HCM. My dad passed away 6/7/2008. My sister passed away on 6/16. My grandfather passed away on 6/21. My stroke, secondary to endocarditis, was on 6/16 also. So 5 years after my stroke, my sister dies on the same day. I just booked my massage for 6/16 this year. I kind of get away from the world on that day. But in my hand is a very old book. It was my mother's diary when she was dating my father. And she was not a big writer. Most of this book is empty, and I always have to figure out which side actually has writing in it. But on June 21st, 1953, I believe it is. Yep, here it is. This is my mother's writing. I don't know how well you can see it. I'll read you part of it. At about 1 a.m. today, Larry's father died suddenly of a heart attack. Why such a lovely man would be taken so young and he was so swell, I'll never know. It doesn't seem fair. I don't know how you can ever forget the look in Larry's face when he came to me to tell me that his father has passed. This is called generational grief. It stays with the family. Beyond the writing, the ripple effect. We here at the HCMA are going to try to stop that ripple effect for other families to ensure that they live long and happy lives. This is my grandfather, probably by the age of the kids around him, probably about 3 years before he died. This is Lawrie at 19. She looks gorgeous and doesn't have any gray hair. That's why I used that picture. And that was my dad. So this is serious, folks. Family is why I do what I do. So I want to thank everybody tonight for their time and attention, for the faculty for sharing their knowledge with all of us, to all of our Center of Excellence partners, to our staff, to the board, and of course to Brandy, my heart donor. For without her, I would not be here today. And I'm going to hand it back to Miguel.
Thank you. Let me see if I can share my screen. Here it is. Let me make sure when I do presentation that it goes in the right. Are you seeing the right part, or let me swap screens? I think that's what I need
No,
to do.
I think you're good.
It's
looks
good?
Yeah.
Okay. So I'm going to be discussing arrhythmias in hypertrophic cardiomyopathy. And all the time you hear about hypertrophic cardiomyopathy as an obstructive disease caused by excessive muscle. And that is true. It's more of a plumbing problem than an electrical problem. But you have to understand that the heart, and I'm sure that someone will not like this, the heart is nothing without electricity. You need the electricity to make the heart pump in a coordinated fashion. And if it's not beating in a coordinated fashion, it doesn't pump. You go into rhythms like this. This is called ventricular fibrillation, or this is an animation trying to portray what ventricular fibrillation is, when the ventricles become desynchronized due to the uncoordinated electricity, and the heart doesn't pump. And you know what happens? You die. So this is something that can happen to patients with hypertrophic cardiomyopathy. And that is because the excessive heart muscle that tends to overgrow in the septum, in some patients is in the apex, but most commonly in the septum, that excessive heart muscle may be prone to discoordinated electricity. And if the wave of electricity gets broken down and it goes from something like here, when it's perfectly smooth and following these wirings, when the electricity does not follow these wirings, then there's no contraction. And a strong heart, and like Dr. Nagueh said earlier, even stronger than normal heart, may be unable to pump at all because of ventricular fibrillation, and you can die. That's the reason for sudden cardiac death. That's not the only problem that can happen electrically in cardiomyopathy. There are several problems, several kinds of cardiac arrhythmias in hypertrophic cardiomyopathy, and this is kind of the outline of my talk. Actually, the most common one is not, surprisingly, it's not a problem of the ventricles, but it's atrial fibrillation, is discoordinated electrical activations of the upper chambers, nothing to do with the lower chambers. And you have to think about the upper chambers as kind of the weakest link in the heart. So when the lower chambers, when the ventricles are hypertrophied and stiff, that leads to high pressures in the upper chambers. And the upper chambers are very thin. They're a chamber for blood to just go through kind of in a passing way towards the ventricle. And when the pressure goes up in the upper chambers, they will dilate. And when the upper chambers dilate, it creates scar tissue, what we call fibrosis, and that can lead to discoordinated electricity. And that is, in consequence, that is the most common arrhythmia problem in hypertrophic cardiomyopathy. The next one and most lethal is ventricular fibrillation, as I explained earlier, where there is discoordinated electrical activity in the lower chambers. Following that is ventricular tachycardia. The difference between tachycardia and fibrillation is that tachycardia is a regular but rapid heart beating of the lower chambers. And that can occur in situations of scar tissue where electricity can spin around the scar and make your heart go regularly, but at about 200 beats per minute, enough again to kill you. And then a few words about slow heartbeats, that is bradycardias, and the role of pacing in hypertrophic cardiomyopathy. So let's talk about atrial fibrillation. You will see it in the electrocardiogram as discoordinated, not these spikes, these are the lower chambers, these are the QRSs, but in between the spikes, you see discoordinated kind of waves. That's caused by discoordinated upper chamber electricity. Most commonly, this tends to be originated in one of the 4 tubes that connect the left atrium with the lungs. They're called pulmonary veins, but sometimes it's due to other mechanisms. And the consequence of atrial fibrillation is that your lower chambers will beat irregular and in general faster than normal. And patients feel that. Patients will get short of breath. Remember that patients with hypertrophic cardiomyopathy, because the lower chambers are stiff, they depend on the upper chamber contraction to fill the lower chambers. And if the upper chambers are in atrial fibrillation, the lower chambers will not get filled, and then the patient will get short of breath. Not only that, because the upper chambers are beating so fast, the upper chambers don't squeeze blood. And pay attention to this little pouch. This pouch is called the left atrial appendage. Well, you know what happens in atrial fibrillation in the left atrial appendage? This is the left atrial appendage. It doesn't move, so blood will become stagnant, and a stagnant blood will tend to clot. A clot may form in this pouch called the left atrial appendage. And if a clot forms, it can go to your brain and give you a stroke. So the left atrial appendage is a common source of stroke risk in patients with atrial fibrillation, particularly so in hypertrophic cardiomyopathy. So this is the reason why patients with hypertrophic cardiomyopathy and atrial fibrillation need to be on blood thinners so that blood doesn't clot and we prevent strokes. How do we, in general, how do we decide which patients need to be on blood thinners? Well, we have a scoring system that we use for patients that have atrial fibrillation, and it's called the CHADS-VASc score. CHADS-VASc is an acronym. The C stands for congestive heart failure. The H stands for hypertension. The A2 is for H more than 75, you get 2 points. The D for diabetes, and the S2 stands for stroke. So if you had a stroke, your risk of subsequent strokes are higher, meaning that we're very good at predicting the second stroke, not so good at predicting the first one. V stands for vascular disease, A for H more than 65, and SC is sex category. Females tend to have a higher risk of stroke. So the higher this score is in a patient with atrial fibrillation, the higher the risk of stroke, as you can see here. And this is what we use for patients with atrial fibrillation in general. However, we have to be very aware, and this is one of the take-home messages that I want to convey today. Hypertrophic cardiomyopathy patients are different. How so? This score that we use for everybody in atrial fibrillation around the world does not matter in atrial fibrillation and hypertrophic cardiomyopathy. If you have those two, no matter how young you are, how free from hypertension or diabetes or previous strokes, you have a higher risk of stroke and you need to be on blood thinners. So hypertrophic cardiomyopathy does not follow this conventional scoring system. And this is something that I see not every doctor knows. This CHADS-VASc score is very popular and very well known by everybody in cardiology. But what not everybody knows is that in hypertrophic cardiomyopathy, it doesn't matter. The combination of hypertrophic cardiomyopathy and atrial fibrillation equals blood thinners, period. No aspirin, no Plavix. It has to be either warfarin, Coumadin, Eliquis, Xarelto, or one of the others, but true blood thinners. A few definitions about atrial fibrillation that is important for people to understand when we talk about it. Paroxysmal atrial fibrillation is AFib that comes and goes, and it never lasts more than 7 days. That's very common, and it will lead to intermittent symptoms. Persistent atrial fibrillation is defined as that atrial fibrillation that is continuous for more than 7 days. And if it lasts more than 12 months, that is considered long-standing persistent atrial fibrillation. And permanent atrial fibrillation is the kind of AFib that we just give up on, that we don't try to correct. So to summarize, what is important about atrial fibrillation and hypertrophic cardiomyopathy? It happens in about 20% of the patients with hypertrophic cardiomyopathy. It's more frequent in older patients and in patients with outflow obstruction. Why is that? Because the pressures in the upper chambers are higher if you have outflow obstruction, and that stretches the upper chambers. And older patients tend to have more scar tissue. 74% of the patients that have AFib have it paroxysmal. That means that comes and goes. And 26% have persistent or permanent atrial fibrillation, meaning that stays there all the time. Interestingly, atrial fibrillation, as uncomfortable as it can be, it does not increase the risk of sudden death. Sudden death is a ventricular problem. It's a lower chamber problem. And the CHA2DS2-VASc score does not predict stroke risk in hypertrophic cardiomyopathy. That's very important to keep in mind. Hypertrophic cardiomyopathy and atrial fibrillation is an indication to give blood thinners, anticoagulate regardless of the CHA2DS2-VASc score. Catheter ablation is a procedure that we do through the groin, getting to the left atrium to cauterize the areas where atrial fibrillation is maintained. And it can work in patients with hypertrophic cardiomyopathy, but they need to know that compared to other patients, the chances of ablation failure is higher, and the need for repeat procedures is also higher than in patients without hypertrophic cardiomyopathy. That is why if you need surgery for a myectomy, as I'm sure Dr. Lawrie will explain later, and you have atrial fibrillation, you should have a surgical AFib ablation. The surgeons, I had to admit it, but they can do a better job at atrial fibrillation once you pay the price of opening the chest. So how about ventricular fibrillation? As I explained earlier, ventricular fibrillation is disorganized electricity in the lower chambers. There's no coordinated pumping, and the patient dies unless you get shocked. So we know that hypertrophic cardiomyopathy patients have an increased risk of sudden cardiac death. And it's very important. It's the number one priority when a doctor evaluates a patient with hypertrophic cardiomyopathy is to assess the risk of sudden cardiac death to decide whether they would benefit from an implantable cardioverter defibrillator. That is a device that will shock your heart into normal rhythm automatically should you develop ventricular fibrillation. So when do we implant a defibrillator? In patients that have been otherwise healthy, what we call primary prevention. So the patient has been fine and they have a recent diagnosis of hypertrophic cardiomyopathy. When do we implant? Immediately after we have the diagnosis? Well, we know there are a few key very high risk factors. Number one, severe hypertrophy. If your septum is more than 30 millimeters in thickness, we know there's a very high chance of electricity getting uncoordinated in the septum where the hypertrophy is, and a high chance of ventricular fibrillation, so therefore you implant. If there's a family history of sudden death in a first-degree relative, you don't want to gamble. We know that mutation that led to the disease in the family member that died is high risk by definition, therefore you implant ahead of time. If you have a recent unexplained syncope, it's important to know what unexplained means. So unrelated to the obstruction and with no other cause, then you want to implant because we think that a syncope might have been ventricular fibrillation that by some miraculous reason stopped by itself. And this is less clear and less well known, but burnt out hypertrophic cardiomyopathy where the ejection fraction has decreased is also considered high risk for sudden cardiac death. Sorry. Other risk factors, we have non-sustained ventricular tachycardia on a 24-hour Holter, or abnormally low blood pressure response to exercise, or marked late gadolinium enhancement, that is scar as seen by MRI, more than 15%.
I'm just in the seminar here.
Apical aneurysm and certain genetic mutations. I remember troponin T is one of those that is known to lead to high risk of sudden cardiac death. Of course,
Yeah,
if
definitely.
someone has survived sudden cardiac death, then you need to implant. You don't want to gamble. So obviously, if you survive sudden cardiac death or you have sustained ventricular tachycardia, then you need to prevent sudden cardiac death with a defibrillator. If you have syncope, like I said earlier, a thorough evaluation for provoked obstruction is the first required to avoid ICD implant in someone that just passed out because of the obstruction rather than from the ventricular arrhythmias. And these risks are dynamic. So you need to periodically reassess. In someone that you thought it was low risk and then they have palpitations, you need to repeat a Holter to see if they have non-sustained VT, because that would be an indication for ICD, particularly in the younger patients and those with borderline risk factors. Few words just to finalize quickly. Ventricular tachycardia can be a source of regular rapid beats from the lower chambers that can lead to syncope and symptoms. It's more common in apical cardiomyopathy, particularly with apical aneurysm. This is one of our cases, a patient that had apical hypertrophy with an apical aneurysm. We were able to squeeze in an ablation catheter and perform an ablation. This is the shape of the ventricle. This indentation here is where the muscle, the thick muscle would be, and this is the dilated apex. And these dots are spots where we ablated. Sometimes it requires to go in the outer surface of the heart, and sometimes requires surgery. A few words about low heartbeats, slow heartbeats, bradycardias, and pacemakers. So typically, hypertrophic cardiomyopathy by itself does not lead to slow heartbeats. But if your surgeon does a myectomy or your interventional cardiologist does a septal alcohol ablation, the conduction system of the heart, the natural wiring of the heart may be compromised, and pacing may be required because atrioventricular block, so blockage of electricity from the upper chambers into the lower chambers may happen. But by itself, outside that scenario, there's no role of pacing as part of the management of hypertrophic cardiomyopathy. Back in the early 90s, there was a study looking at pacing-induced desynchrony as a way to treat hypertrophic cardiomyopathy, and it wasn't shown to be beneficial. So the take-home messages are that although hypertrophic cardiomyopathy is mostly a ventricular disease, atrial fibrillation is the most common arrhythmia, and it requires anticoagulation irrespective of the CHA2DS2-VASc score. It may respond to ablation, particularly surgical. Sudden cardiac death requires risk assessment and ICD implant for indicated primary and secondary prevention, as I just described. Catheter ablation may be required for ventricular tachycardia, and pacemakers may be needed after septal myectomy or a septal alcohol ablation. And I'll stop there. Thank you very much.
Thank you very much.
Any questions?
I'm sorry, my phone rang as you were finishing. I'm like, I can't talk now.
That's all right.
Sorry, real life happening in real time. So little known fact about yours truly. I believe I was patient 106 in the dual chamber pacing trial.
Empathy, right? It was called Empathy.
No, this was before it had a name.
Oh, okay.
This was way back when. And I was, my sister was number 23 and I was number 106, I think. And it didn't work. Just so you know, didn't work. So that is an N of 2, but still it was.
Listen, thank you for being part of a study because that's how we learn.
It is how we learn. And I've got the scar to prove it. It ended up getting replaced with a defibrillator, which ended up doing not much either, but was there for protection. So there's a lot to unpack in your talk. I encourage anybody who's online to use the Q&A feature, not the chat feature. It's a little harder to manage and we can't make sure that we get everything answered. And so you can use the Q&A feature if you want to. Just to follow up in terms of paroxysmal AFib. So AFibs that comes and goes. Do you have to anticoagulate all the time? Can you risk it? And what are you actually risking by not anticoagulating?
So in general, the conventional wisdom is paroxysmal atrial fibrillation has equal risk as persistent. And that comes from a lot of studies that were not designed to study this, but studies of anticoagulation in general and stroke protection were shown that paroxysmal atrial fibrillation had similar risk. There's new studies going on in patients that have pacemakers or defibrillators in whom we know with 100% certainty how much AFib they have. And there's one, Medtronic has a study looking at anticoagulating only when the patient has a fib as detected by the pacemaker or defibrillator. That's still unknown. The problem with assuming that you can only you could get away just giving blood thinners when you have an AFib episode is that you cannot trust fully the patient. You need an implanted device to tell you. And most patients don't have an implanted device. So in general, the risk is the same. And we cannot assume that just because you have AFib that you feel once every 6 months, you're safe not taking anticoagulation, because number one, you may have episodes every night that you don't feel, and then yet they put you at risk of stroke. And number two, the pathogenesis of stroke in AFib is a little bit is a bit more complex than you would think, because you may have a stroke 2 or 3 days after an episode of AFib that had already subsided. It all comes down to when a clot forms and when that clot leaves the appendage to go to your brain.
And we're trying to avoid that, aren't we? I know patients don't always like being on anticoagulants, but I assure you, I've had a stroke, not something that I highly recommend. And the one thing they don't tell you about strokes, in case this is a decision maker for some people, it's very painful. It's incredibly painful. And the loss of function can last a lifetime. Other little known fact about Lisa, I'm partially blind in my left eye. Didn't know that, did you? That was from the stroke. I lost part of my vision. So don't lose your vision. Don't have a stroke. Don't lose part of your brain. Anticoagulate if you're an AFib patient. We have a question coming in down here. Let's take a look. Does having non-sustained VT often lead to heart failure sooner? I have an ICD. It very seldom needs to pace and no shocks, but I'm told I often have non-sustained VT and I feel it often. So is there a prognostic value to recurrent NSVT?
Well, not in terms of heart failure, but non-sustained VT it increases the chances of sustained VT and then needing shocks. And of course, you get many, many shocks, you could end up in heart failure. But as far as the plumbing problem does not get worse with non-sustained VT.
Okay, Jamie, we did a live answer for you there. Thank you for using the Q&A box, and I hope that answered your question. Okay, so we've got a little bit of a quiet crowd tonight. I thought you Texas folks were very, big, so big questions. Come on, bring it. So hopefully we'll get them to do that soon. So we're going to move on to our next talk now. John Buergler is going to discuss alcohol septal ablation, purposely creating a heart attack to help us. Explain.
Yes, exciting. So first, let me see if I can find my screen here. Give me a moment and see if I can grab it.
Oh, we have another question while you're grabbing. Oh, no, we don't have another question. I forgot to hit the done button. Okay.
Okay, there you go. Can everybody see that all right?
You're good to go. Take it away.
All right, everybody. So we're going to talk about hypertrophic cardiomyopathy and alcohol septal ablation, the Methodist experience. First, we have to talk a little bit about medical therapy, because if you show up and you have hypertrophic cardiomyopathy, you don't immediately get a myectomy or an alcohol septal ablation. First of all, only about 20% of patients that have hypertrophic cardiomyopathy are actually obstructed. And so this septal reductions therapy, the alcohol septal ablation, would only be applicable to the subgroup of 20% of patients that are actually obstructed. And of those, they need to be on optimal medical therapy. So what is optimal medical therapy? Well, usually the first line therapy is a beta blocker. Metoprolol is a beta blocker. There are others. You would start it and then you would titrate it up to the maximum tolerated dose, and hopefully with the beta blocker you would feel better. Alternatives would also include verapamil, which would be very reasonable. And we use other medicines as well to try and improve the symptoms that are caused by the obstruction of hypertrophic obstructive cardiomyopathy. Other medicines can make the obstruction worse. So diuretics are often a culprit. And so occasionally diuretics are needed in hypertrophic obstructive cardiomyopathy, but they should be used judiciously. Vasodilatory antihypertensives can also worsen obstruction. These are ACE inhibitors or angiotensin receptor blockers or hydralazine or nifedipine. These can all worsen obstruction. If they're on your medication profile, we will look at potential alternatives if it's feasible so that we can optimize your medical therapy prior to doing anything else. In addition to optimizing your medicines, you would then have to continue to have symptoms despite that. That would include having shortness of breath, which would be heart failure, chest discomfort, which would be angina, or repeated syncopal episodes. And these would have to be enough to interfere with your ordinary life. In addition to the symptoms that happen despite optimal medical therapy, there's anatomical criterion that I think Dr. Nagueh mentioned earlier, that the septum has to be greater than or equal to 1.6 centimeters. You saw good examples of that already. Septal to posterior wall ratio greater than or equal to 1.3. Then in addition, you either have to have a resting gradient in the left ventricular outflow tract, or at rest, or with provocation, which is Valsalva. There was a question about that at the start, what Valsalva is, and that's where you bear down, you increase your intrathoracic pressures, you decrease your venous return, and you worsen your obstruction. In addition, there must also be systolic anterior motion of the mitral valve. So what is alcohol septal ablation? Well, Lisa said it very well. We're actually causing a heart attack. Historically, there was not much to be done for patients with hypertrophic cardiomyopathy, even though Brunwald and others described it and compared it to the hemodynamics of aortic stenosis in the 1960s. But there was an observation made that occasionally somebody would actually have a heart attack due to coronary disease, and they would actually feel better afterwards. That led us to the suspicion that if you could get rid of the extra heart muscle by a heart attack or by surgery, you would feel better. And in fact, that's what alcohol septal ablation is. It's getting rid of the blood supply to the extra heart muscle, which is in the septum. And the artery that supplies that is the septal perforator. And so in the ablation, we use a catheter in the cath lab. We go into an artery and we go that route. There are some exclusions. There's many, just a couple simple ones, or that they're uncontrolled arrhythmias. We would refer them to Dr. Valderrabano in our group or one of our associates to try and control the arrhythmias prior to doing the procedure. Once in a while, not commonly, there could be unsuitable coronary artery anatomy, such as a very small septal perforator, but this is not usually the case. You've seen these echoes before, so from Dr. Nagueh's talk, and so you're an expert, but on the left would be a patient with hypertrophic cardiomyopathy. You can see this big, thick septum and the mitral valve right here. And on the right, you can see sort of a more normal appearing heart. And remember, it's in this area of the septum where we're gonna induce the heart attack to reduce that thickened heart muscle to get rid of the obstruction. Well, this is an old newspaper clip. I dug it up and put it on this slide for this talk. This goes back into history, November 14th, 1996. There indeed history was made. The first alcohol septal ablation in the United States was done right here at Houston Methodist Hospital. You can see the doctors there getting prepared to do it. One of the doctors there, Dr. Spencer, went to Europe to train with Dr. Ulrich Sigwart, who did the first alcohol septal ablation ever. He took that expertise back to Houston Methodist Hospital, where we've refined that expertise further with repeated alcohol septal ablations, refined our techniques in terms of amount of alcohol given, using echocardiogram, and using other modalities to make it even safer than the initial days. What are the nuts and bolts of the alcohol septal ablation? Well, you have to have one tube into an artery, either a radial artery or femoral artery, and you need that to do the procedure, inject dye down the arteries, and to give the alcohol. You need another arterial sheath to measure continuous pressure in the left ventricle, because we're going to follow that throughout the case and compare that to the aortic pressure, and that will help us gauge our progress during the procedure. In addition, Dr. Valderrabano alluded to this. Sometimes you may require a pacemaker as a result of alcohol septal ablation. So if you do not have a permanent pacemaker or a permanent AICD in place, a temporary pacemaker will be placed through the venous sheath at the time of the procedure. We will measure then pressures in the ventricle and the aorta, and that difference will be recorded, and that will be our baseline pre-procedure gradient prior to doing the procedure. We will then do a diagnostic angiogram involving contrast, where we inject dye through the catheter, and we will identify the candidate for septal. So I'm going to give you some examples in a moment. So here is a baseline gradient. The blue is the ventricular pressure, the red is the aortic pressure, and this would be a typical patient with hypertrophic obstructive cardiomyopathy who at rest has approximately 40 millimeter gradient. This would be this is a coronary angiogram, and I'm going to use my mouse here to show you this is the left anterior descending, and this artery right here that's going down is the septal perforator. It's this first septal perforator that we will use to figure out if this is a good area for the alcohol itself. Once we're in that candidate septal, we inflate a balloon, and here's a picture with the balloon inflated. This is our catheter here. The other things that we talked about are also in this slide. Here's the temporary pacemaker wire. This is the catheter in the LV apex, which is continually monitoring all the pressures. We get the baseline gradient, which I showed you previously, and then we inflate the balloon and we inject contrast down the septal. So here is an example of the balloon inflated, and we're injecting through the shaft of the balloon contrast down the septum. The reason that's important is we want to make sure that that contrast does not go anywhere else, but only stays in the septal artery. This ensures that when we give the alcohol, it stays where it's supposed to be. The role of echo during alcohol septal ablation is very important. Dr. Nagueh mentioned that in detail. It identifies potential size and territory of the infarct. It avoids infarct in undesired territories. This is an example that he did a long time ago, where this is the septum in question, and you can see the hypertrophy. When we inject contrast, you can see it light up, and this is the potential infarct area. And then here after we've given the alcohol. So if for some reason we gave the contrast and it lit up in another area, we would simply deflate the balloon, and we would look to another place to give the alcohol. But in this case, it was a good area, the alcohol was given, and it was a successful procedure. So we have a 3-step checklist when we do our alcohol septal ablation. 1, contrast is going down the septal only, and the balloon is not obstructing flow down the left anterior descending. The echo, as you just saw, confirms the correct area of the potential infarct. And thirdly, with the balloon inflated, you develop stunned myocardium, where the heart does not contract appropriately because it's not getting adequate blood flow because the balloon is inflated. As a result, there will be a reduction in gradient where there will be an increase in systolic blood pressure and a decrease in the obstruction. These are examples from other institutions where echo was useful. Here you can see that there's RV opacification with echo during alcohol septal ablation. Here is one in the middle slide where there's lateral wall opacification, and on the right, during alcohol septal ablation due to balloon rupture and alcohol leak into the left anterior descending. Here's an example of papillary muscle opacification with echo during alcohol septal ablation as well. And our patient didn't have any of those. It was a good candidate. We injected alcohol down it, and this would be the final result where the septal perforator is occluded. You no longer see it on the angiogram. This is the point where the patient's actually having a heart attack. How do we give the alcohol? Well, this was developed over a period of time. Initially, we gave the alcohol and we had successful procedures, although there was an increased incidence of heart block and pacemaker implantation. So with further experience of doing this procedure, we realized that we needed to decrease the amount of alcohol that had to be given, as well as the rate at which it's given. So in this slide, this is a reminder that we give 1.5 to 2 cc's of alcohol, usually slowly through the shaft of the balloon. We give medicine for the patient to make sure they feel comfortable. We then deflate the balloon, remove the equipment, and repeat the gradients. And if the gradient is still greater than or equal to 30, we would then do the procedure again on another septal in the same way that we did the first septal perforator. Sometimes we'll even be aggressive and we will go after another additional septal perforator, even if the gradient isn't quite 30, but it looks like there's a good candidate because we've known through experience, the lower we get the gradient at the time of the procedure, the more likely the procedure is to be long lasting and patient have excellent recovery of their symptoms. If we're done, the catheter is removed, we do a final angiogram of the left system, we turn off the anticoagulation, we make sure the pacemaker is working, and then you go to the CCU. So after you have a heart attack, we don't send you home right away. I'm sure you wouldn't think that. We would send you to the CCU for 24 hours, and we would watch you carefully with your heart attack, look for any arrhythmias, look for any potential complications. Here's a couple of examples before and after alcohol septal ablation. Again, where I have my arrow. This is the open septal, and here's an occluded septal before and after. This is a typical gradient afterwards where there's minimal, if any, gradient between the left ventricle and the aorta. Remember that if there's a small residual gradient, in all likelihood over the next several months, the heart will continue to remodel itself, and the gradient should also continue to go down. You would stay in the ICU with the pacemaker wire in overnight. You would look to see if the pacemaker wire is needed the following day. If it's not needed, you would pull the temporary pacemaker wire out. You'd follow the heart enzymes. In general, patients, of course, were on beta blockers coming into the procedure. Usually the beta blockers are roughly halved after the procedure. In general, patients would be observed an additional 24 hours on telemetry after transfer out of the CCU. There shouldn't be any driving for at least a couple of weeks. There should be periodic clinical follow-up, including echo and MbO2, so we can objectively show how much better you are in addition to improving symptoms. Just a historical brief couple of slides. There was something we've used for many years called stereotaxis, which is a magnet used to direct the wire. We did the first, this is a picture of the device that we were using. We did the first reported consecutive series of magnetic navigation and alcohol septal ablation. We had good outcomes. We got better with wiring it as we got more experience, but because our success rate was pretty high with conventional means, we could not prove an additional benefit with stereotaxis, although we're always looking at new ways to make the procedure newer and safer. As an example of the 45 patients that with time going from left to right, you can see that our wiring time got better. And you can see with more difficult cases, it could be used, such as this strange looking septal that we ablated here. We injected contrast down it, and now it's gone. So we concluded back then that basically it was safe and effective, but we needed more studies. And as we got experience, we got better with it. Again, the success rate with a traditional alcohol septal ablation is 95%. So again, with alcohol septal ablation, your first step is to treat medically, up-titrate the medicines. After you've up-titrated the medicines and optimized them, you make sure that they're an acceptable candidate anatomically with echo. Dr. Nagueh and Dr. Valderrabano also mentioned the role of cardiac MRI. And then you do the procedure as we described. We figure out the candidate septal. We use echo. We do our 3-step checklist to make sure we're in the right spot. You go to the ICU for a day, and then you go to the floor for a day, and then you usually go home. And I think that is the end of my presentation. Thank you very much.
Thank you. That was interesting, and I love the old paper. Other little known HCMA fact: when Bill Spencer was doing his first procedures, he contacted us, and the procedure was in one of the very first paper newsletters of the HCMA, and we actually recruited like 5 or 6 of the original cases that Bill actually did. And one day, well, at a conference story night, that's the theme, Bill was at a restaurant and I was at the same restaurant. He was eating alone, and he had just given his talk where he puts the bottle of Absolute up with the ice. And I thought it would be cute if I sent him a double Absolute on the rocks. So I did, and I made him drink the whole thing. He was feeling pretty good by the end of the night.
I bet he was. Wow, that was great.
Yeah, it was actually kind of funny. I'm like, I gotta do it. I gotta send him a double Absolute on the rocks. So I did. HCM is serious business, but sometimes we have to have a little fun now, don't we? Okay, so we have a question. It's about imaging. I'm going to hold it for right now because I want to see if there's any questions about alcohol septal ablation, the procedure. Here we go. What are the side effects of alcohol ablation? Does it stop the disease from progressing and no more heart failure? Mm-mm.
Wow. Okay. So, well, the side effects of alcohol ablation. So, first of all, there's short-term side effects while you're having the myocardial infarction. We talked before about the need potentially of a permanent pacemaker, which is approximately 10%, but was much higher in the initial few patients that we did until we got better at it. The alcohol creates a scar, which can theoretically create rhythm issues. And so that always needs to be observed. The disease does not stop progressing, however. So if the goal is to get rid of the gradient, and then your symptoms should be good. You say, well, what's been our experience? Well, if you do an alcohol septal ablation here, your probability about requiring a second procedure to decrease your obstruction is about 1 in 6. That means there's about a 5 in 6 chance that you would need another procedure. And that is because the disease does continue to progress. And so in certain patients, you might need to do an additional procedure like a repeat alcohol or perhaps a myectomy.
So there's no free lunch. You can't have a heart attack and not have HCM anymore. You still have hypertrophic cardiomyopathy. You've resolved the obstruction, hopefully. You've developed a right bundle branch block, which probably doesn't matter much, as long as you got a functioning left. And in skilled hands, the potential for catastrophic outcomes is negligible. But in unskilled hands, how does it go?
Ms. Lisa, I want to take this opportunity to emphasize a point. It appears easier for some cardiologists, but patients need to sort of inquire carefully and ask, where is it done? How many of these procedures has that cardiologist done? And also be very careful. Have they undergone? Dr. Buergler wrote about many issues that we have to look at before we proceed. How severe are the symptoms? How much of the medicines have been given? So before jumping to alcohol ablation, very important to look at all these issues. And most reliable if you get your procedure in a center of excellence, not in a community hospital.
Especially not a community hospital in Texas. That was happening for a while. It's calmed down again and we've pulled it all back in, which is fantastic. But the driver of the decision of tonight's head-to-head competition, alcohol ablation versus myectomy, myectomy coming up next. The driver is really the underlying anatomy. Would that be correct?
Yes, I think that's true. So in particular, we look very hard for myectomy for all of our patients. A lot of patients want the non-invasive route, but we really do try and let them know that in skilled hands, and Dr. Lawrie is extremely skilled, the mortality is under 1%. And it's unlikely you would need another procedure, probably even less so than with an alcohol ablation in my estimation. I think that in Dr. Lawrie's hands, the probability about requiring another procedure is probably less than the 16% I quoted you with an alcohol ablation. There's always a theoretical risk of scar. Anatomically is a good point. So a thicker septum will likely do better with myectomy. So for instance, if you are 2 centimeters, we will really be pushing somebody to think about a myectomy, because probably in that subgroup of patients, the probability of needing a repeat procedure at some point during your lifetime would probably be high.
And on the other side, if you don't have a great deal of hypertrophy, it probably won't work so well either, because the mitral valve is probably driving the process, correct?
Possibly so. Dr. Nagueh, any comments about that?
Correct. If the septum is not that thick, the mitral valve is usually the abnormal anatomy of the mitral valve is the driving factor. And that offers alternatives with surgery, and sometimes in patients who go through what we call a clip procedure. The more scientific name for that is the transcutaneous edge-to-edge repair. And that is also done by interventional cardiology. And again, centers of excellence would be best suited to look at the particular patient situation and come up with the best recommendation that suits their septal thickness and their mitral valve pathology.
Yeah, in fact, we had a grand rounds a few years ago where we actually talked about the role of clipping and hypertrophic cardiomyopathy as an adjunct to all these other therapies, and we had a really good discussion about that.
I can remember when the mitral clip was just coming out, and I'm thinking, is there a place here for that? And I know Paul Staraja wrote a small paper on a couple of cases with elderly using mitral clip. And I thought that was really fascinating. We haven't talked about that much in the Bighearted tour. We'll try to include some mitral clip data in a future episode. So stay tuned for more. Okay, we don't have any other questions right now. You're free to continue to populate the Q&A, and we'll get to that in a little bit. And without any further ado, we're going to bring up Dr. Lawrie, who has quite a reputation outside of HCM. He has a couple of, somewhat famous patients that some people might know who they were, but we won't talk about that. And he has an extensive experience that in hypertrophic cardiomyopathy and myectomy. So Dr. Lawrie, I'm going to ask you to share your screen and take center stage.
Thank you very much, Lisa. I really appreciate the opportunity to be here.
Just got to get that screen share button to go, and we're good.
I'm having a little screen share issue here.
Yeah.
I'm on the share screen, and I've gone to advanced.
It should just be share screen and go. There shouldn't be an advanced option.
Oh, okay.
And you should choose the screen that you want to share at that point.
PowerPoint.
Yeah, the share screen button is in green with an up arrow.
Right, I've got
next
that.
to the chat.
And then what next?
You choose the screen that you would like to share.
One of the examples here.
Yep.
What would that be? PowerPoint?
That'll be that one.
Yep.
It still didn't go.
And then click the. I've got
you click the screen that you want to share and then hit the share button, which should be blue in the lower right corner. I love technology.
Yeah, me too.
It has not been cooperating with me today. My PowerPoint blew up already today and I had to use Google Drive's PowerPoint.
Sorry for the delay here.
Not a problem.
Hokum surgery, that should do it.
Yay. Okay. Starts. There you go. Ta-da.
Well, thank you again. We're going to talk about the role of surgery, and it's interesting that we're up at about the 60-year history of the use of surgery for hokum. Oh boy.
I'm honestly not quite sure how you've got the view that you've got, but it's really cool. Your slide is somehow behind you and it's your backdrop now.
Yeah, I can see that.
I would love that for all.
Yeah. Okay. So
Well, I'm not sure I want to feature my face in the middle of this. Should I do that again?
yeah, I'm gonna take the screen share away from you. Option, stop screen share. Let's try that again. That was kind of odd.
Okay, share screen,
And then
click item, and then share. And now I'll get it out of this.
we're back to the same.
Oh,
one.
well.
Well,
The
see what
problem-
happens if you go to the next slide. I'm not sure if it'll even go.
Well, it's not moving. That's the problem.
Yeah, I think you actually made this your backdrop. Okay, let's.
If you're sharing slides.
Well, I can offer a solution. I can have you email the slides to somebody else, and then we can try to do a screen share elsewhere. That's option one. Or you can.
Hang on, back into the.
Not working.
No, I've had this up. Should I log back onto the whole thing?
No, that shouldn't be necessary. I'm trying to think of how I can assist you
Screen.
here.
Hokum share. It says here I'm
Okay,
screen.
so go to the file that you'd like us to see at this point.
Yep.
Bring it up, double click it. I think we'll be good here.
Yeah, there we are.
We're good
Sorry.
here. We'll
I
stay here.
apologize for all this. I was doing it repeatedly, rehearsing it, was doing great.
Well, now you have mastered this skill too. Thank you.
I'm glad we've all been able to have a little breather here while watching human suffering. It's always good to be the observer. So we're going to talk about the surgical aspects of hokum. And hokum, as has been said, is a disease of the LVOT, of LVOT obstruction, according to Dr. Marin. And so we really need to be aware of what the LVOT is. So if we look at the heart here with the front taken off, we've got the right ventricle, we've got the interventricular septum, we've got the left ventricle. And what's meant to happen is that blood flows into the left ventricle through the mitral valve here, such an anterior and posterior leaflet, comes down, does a 180, and then gets pumped out through the aortic valve here. And if we go to this little animation, we can see the blood flowing in. And as the blood flows in, the anterior leaflet of the mitral valve gets pushed forward. But then as the heart starts to contract normally, it gets pushed back out of the way, and this opening becomes larger. You can imagine if you have a big lump here in this area, then problems can arise with the anterior leaflet being pushed this direction while the heart's trying to push the blood out rather than going back out of the way. And this is called systolic anterior motion of the mitral leaflet. And it, along with the hypertrophy, are the major causes of obstruction. The first report of asymmetrical hypertrophy of the heart was by Dr. Tier in 1958. And this is the kind of pathology people were dealing with in those days. This is the interventricular septum here. And you can see the aortic valve here, the blood's pumped through. This is the anterior leaflet. And this little slit here is the left ventricular outflow tract. So it's not surprising that these young people were dying from this pathology. So in that same year, after this description, Dr. Cleland was sent someone with subaortic stenosis. At operation, he put his finger down through the aorta into the outflow tract and found an enormously enlarged ventricular septum. He resected part of this, and remarkably, the patients recovered, even though this is 1958, and was greatly relieved. The first type of this surgery in the United States was in 1961 by Dr. Kirkland at Ellis. And basically they were resecting somewhat better pathology, but he came up with the idea of putting a finger through the aorta to be able to define where the obstruction was, and then make a cut down here in the wall of the ventricle near the apex and work through that to do the actual resecting. He had pretty good results with that too. But the real era of consistent results for surgery from Holcomb was with the pioneering work that began in 1961 at the National Institutes of Health by Dr. Morrow. And interestingly, though, his work began, and the whole success of our efforts to treat Holcomb began on a misconception. Dr. Morrow believed that he was going to fix Holcomb by incising a ring of sphincter-like muscle that would contract in systole and squeeze the opening. So this was a dynamic muscular obstruction, and he was going to cut it open and spread it open to prevent it doing that. So he came up with a little knife that he could strap on the tip of his finger, the little knife blade here. And here you can see he's put his finger down into the heart, through the aorta, down here, and the knife blade on his finger is now running here. And he decided he'd go all the way down to the septum, all the way down the septum, right to the apex. And basically what he was doing, you see here the right ventricle, the septum, and the very small left ventricular cavity. He'd run down here and make a cut through the septum to about 2/3 of its depth. And then he got his finger on the inside and his thumb on the outside and squeezed on this muscle here until it opened up into this wider space. So that's how he started off. After a while, he found that his results were somewhat inconsistent. They were encouraging, but inconsistent. So he started removing more of the lump. That made sense. He started resecting more of the myocardium around the edges of his slit until eventually he came up with a rectangular trench, which was about 1 centimeter wide and about 1.5 centimeter deep. And he decided he didn't need to slit the more normal part of the heart any longer, so he stopped slitting when he got to the bottom of the lump towards the apex. So this procedure was then instituted at the Institute of Health, and over a period of a number of years, several hundred cases were treated, and he reported on these in 1978. And this is what we now know as the classic Morrow technique that is still used in some centers to this very day. And this is basically what it looks like. Patients operated on through a median sternotomy, heads up here. Patient's heart stopped on the heart-lung machine. The aorta is open. This is the aortic valve. This is the hypertroph. It's right in front of you when you get in there and are looking at the aortic valve. And then the ventricle is running in and back behind here. So by making cuts here with a knife, again, through this lump, we're now making a cut parallel to the septum. So you can see this is parallel to the outside of the heart coming through here. 2 separate slits are made, one on each side, and this little 1 centimeter trench is cut here, and this plug of muscle is removed. So once that plug of muscle is removed, we now have a 1 by 1.5 centimeter resection. Not a huge resection by modern standards, but surprisingly effective in very many patients. And here you can see at the base of the aorta, with the right coronary leaflet of the aortic valve, which is our landmark, still to this day, this trench cut out that relieved the obstructing hypertroph. There was really no aspect of this therapy directed at the mitral valve. We didn't really have much knowledge of the behavior of the mitral valve because at that time there was no echo. So it wasn't until 1969 that echo became available, and SAM was diagnosed for the first time, this systolic anterior motion. And it wasn't until 1972 that HOCM was identified on echo. And this is the kind of data that suddenly started becoming available to cardiologists and surgeons, this big hypertrophy here. But in addition, this systolic anterior motion of the anterior leaflet of the mitral valve you see here, getting jammed onto the septum as the heart's contracting, blocking off blood getting into the aorta up here, and at the same time preventing the mitral leaflets getting together and causing mitral regurgitation. So as time went by and echo was more widely used, we started to see that the classic Morrow addressed that left ventricular outflow tract obstruction pretty well, and systolic anterior motion in many patients was relieved. But we became aware that there are a number of anatomic anomalies of the mitral leaflets themselves, part of the genome of HOCM, but not previously fully appreciated as to their significance, and other abnormalities of the chordae and the papillary muscles. And these were identified as abnormalities of the leaflets. HOCM patients in general have bigger leaflets in all respects, but especially the anterior leaflet is affected. And in many cases, the anterior leaflet is up to 30% bigger, especially in its length, than normal leaflets. In addition, we've heard about papillary muscle abnormalities. A common one is for the papillary muscle to insert directly into the leaflet. There's meant to be the leaflet and then the little chordae, and then the chordae are attached to the muscles. And here you can see a big papillary muscle, and it's also coming off the wrong part of the ventricle and coming up. So it's positioning the leaflet into the outflow tract where it can cause obstruction. In addition, as surgeons operate on more people, you can see this very thickened heart. They take the septal area off and get a nice resection there, but still find they had SAM. The leaflet here would continue to be pushed into the septum even after it had been resected. And what was happening was with all this hypertrophy, the papillary muscle down here was essentially trapped and immobilized. And instead of the papillary muscle to be able to move over and carry the anterior leaflet back over to the posterior leaflet out of the outflow tract here, it was being stuck out here where it could get caught and pushed over onto the septum. So with this knowledge in mind, Dr. Messmer in 1994 reported on a formalized version of what many of us had started to do already, which was an extended Morrow technique. And this was introduced to improve relief of obstruction from the hypertroph and to improve the rate at which the mitral valve was restored to normal competence and get it out of the way of the outflow tract. So essentially, in addition to the traditional septal myectomy, which you see marked here, that area would be taken out. The operation is extended to the hypertrophied and malattached papillary muscles to try to hollow things out around the wall near the papillary muscle and the papillary muscles themselves. So you end up with removal of the septum in a more extensive way than the classic Morrow channel, and then making a lot more room around the papillary muscles and thinning out the lower parts of the septum that aren't necessarily part of the hypertroph. And in this way, you can see this whole area now is expected to be much more mobile than over here. And this anterior leaflet in Sicily can now move in this direction instead of being stuck over here and getting pulled over into the septum. And so I would say that worldwide, this is by far the most common technique. Every surgeon has their little minor differences, but this is the core principle of hypertrophic cardiomyopathy surgery to these days. So we'll just look at the application of this technique in a 47-year-old man referred with drug refractory symptoms, history of sudden cardiac death treated 10 years earlier with AICD. I've tried to include all the talks with this one patient. Strong family history of HOCM, normal coronary arteries by cath, subaortic septal hypertrophy with a septal thickness of 2.7 centimeters, moderately severe MR, and an LVOT gradient of 75 millimeters at rest and with provocation going up to 120 millimeters of mercury. Here's his preoperative transesophageal echo, and you can see the left atrium, the left ventricle, the posterior mitral leaflet, anterior mitral leaflet, ascending aorta here, and this big thick septum here measuring 2.7 centimeters wide. And as you look here, you see this anterior leaflet's not performing normally. Instead of coming together and resting over here and sealing off the left ventricle from the left atrium. This middle portion down is being kinked into the top of the septum, and this is blocking the very outflow tract that's supposed to transmit the blood in systole out into the aorta. And if you look here, we can see with the color Doppler put over this area, as the heart's contracting, we've got mitral regurgitation going up into the left atrium, and we've got all this color here, which means the blood is having to squeeze through here at high velocity into the aorta. So the surgery starts with the patient on the heart-lung machine with blood being pumped into the aorta from the heart-lung machine and drained out into the heart-lung machine. The ascending aorta is cross-clamped and a preservative solution given. We're now opening the ascending aorta to start going down to the hypertroph. Now we've enlarged that and we're starting to retract the outflow tract backwards so we can look in here and see what's going on. This is the right coronary leaflet of the aortic valve. And as I said, this is the landmark that was established by Dr. Morrow and is still in use today. This is the main area in which the surgery is centered. We've now moved the retractor down and over the that right coronary leaflet, and you can start to see this muscle here, which should not be there. This is the top of the hypertroph. And as we look backwards here, we can see in the rear here, the anterior mitral leaflet. And looking at it from another angle, you can see the size of this hypertroph, very thickened area. And then in addition, you can see this little white line here. And this is a line of scar tissue. And this is because the anterior leaflet here with every heartbeat has been projected forward and has been hitting this area and causing it to fibrose. And so that's what that white material is. Now we start our resection by getting a knife blade, very similar to those pictures that Dr. Morrow had in his article. And we're going to push this blade all the way into the hypertroph and then bring it across here. And we're going to make sure we bring it further than Dr. Morrow did. We're going to take it all the way to the anterolateral edge of the anterior leaflet. This is because this edge tends to get stuck to the wall of the ventricle. And this is one of the abnormalities we make a point of correcting to ensure things get mobilized. So the blade's going down, it's going into the cavity of the left ventricle in this axis. That's the axis, long axis of the left ventricle. So once we've got the resection started, we're going to continue down this line until we've got through all the hypertroph and all this area's been resected. And in addition, we're usually going to do a little more resection down to about here to make sure we're totally freeing up the papillary muscles. And then after we've removed this, we're going to go back in here and make sure the papillary muscles are completely separated off from the walls of the ventricle, front and back, like this area here is mobilized up. We use scissors for this part, and here we've got the blades of the scissors turned down as we go into the hypertroph and start going back again across in this direction under that anterior leaflet of the mitral valve. And then you'll see here the scissors are turned up. And as you watch here, you'd be able to see those scissors go deeper and deeper until we're up to about the hinge point here. So we'd be going in from this point 3 to 4 centimeters. And I'm sorry, it's almost impossible with a camera in the operating room to get a good picture directly underneath this area in the right into the interior. But here you can see the muscle being separated away. This is this area here heading down, and we're going to continue down until we've gone down about 4.5, 5 centimeters. And here's the specimen. You can see it's about 4.5 to 5 centimeters. This is the side facing the cavity of the left ventricle. And you can see this muscle has been covered in this scar tissue. This is a wide area that anterior mitral leaflet has been hitting the muscle repetitively. And here you can see the deep side. And you can see here, as we talked about on the MRI, there's commonly a lot of scar tissue in these hypertrophs from the tremendous force of contraction inside them, the high tension inside them. And here you can see at the end of the surgery, we have our septal hypertroph before the surgery. You can just barely see the anterior leaflet down there. And now after the surgery, this really remarkably larger outflow tract, and you can see the chordae going down here to the papillary muscles. And if we've been able to get, the problem is with the sterility, you can't get someone's hand in deep enough to look under this edge. But if you looked in there, just up here, you'd see the tips of the papillary muscles fully mobilized away. And so here we are postoperatively with the anterior leaflet, making good apposition with the other mitral leaflet, and the septum trimmed off and flattened out. And then if we look over here, we now have no mitral regurgitation. We have a 5 millimeter gradient across the outflow tract, and this part of the muscle's gone. And this is very unlikely to recur. This is a very definitive and usually lifelong cure of the problem. So in summary, surgery still has probably the most important role to play, and particularly in people with mitral regurgitation, we now know enough about the mitral valve to predict preoperatively who will need an extended or additional therapy that involves active intervention on the mitral leaflet. So alcohol is good at ablating the septum in many cases, but in people with mitral regurgitation, we have to look very critically to see whether they're going to need a separate mitral valve procedure. So again, I'd like to thank Lisa. Her contributions to the well-being of her patients is just truly remarkable. And we're very proud to be associated with her organization and look forward to a very productive association. I'm a big fan of yours, Lisa, I really am.
Well, likewise, that was an absolutely fantastic presentation, and I think really historically put perspective on how far we've come and hopefully leave a little wiggle room for where we can go forward with this. I think myectomy has just improved and enhanced over time with techniques. I consider it more artwork than necessarily just a surgical procedure. You really need that eye to understand the anatomy, and you certainly have an eye for that anatomy. So I tease sometime putting, alcohol ablation head to head with myectomy. They are both elegant procedures when done properly that can have absolutely life-changing improvements to the lives of the people who have them. The explanation point here is in the right hands, in the right hands, in the right hands, in the right hands. And we are happy to have so many wonderful physicians who are the right hands at the right time. So that was fantastic. I love the history. I'm a history geek.
Me too.
I love HCM history. And I was really lucky once to sit with Dr. Brunwald in his office and have him tell me exactly what happened when Mara went into the OR and the whole procedure, and hearing it from the people that were there. Pretty amazing. Absolutely amazing. Okay, ladies and gentlemen, it's time for questions, and here they come. Okay. So Jamie, I know you have a question. I'm going to pause that one for just a second. Okay, Barbara. Is a person with HCM with obstruction doing damage? Oh, you asked this question in the group the other night too. Is somebody doing damage to their heart long-term if they keep obstruction there and don't do anything about it? What is the likelihood that they will progress to heart failure by not getting the myectomy or not being on medication if they just let it ride and let the gradient do what it's going to do? What are the potential downstream consequences of leaving high gradients in place?
So if you leave a high pressure gradient in place and you do not treat it, particularly if the patient is having symptoms from it, the odds are very high they will end up going into heart failure. And while you can treat somebody with heart failure and obstruction with the procedures you just heard about, these can be more challenging and carry a higher risk. So the best time to operate is not wait till the florid heart failure has set in or the more advanced stages of heart failure have arrived, but to act sooner. Not when there are no symptoms or minimal symptoms, but when the symptoms are significant enough that a patient is interfering with their daily activities or they want to be more active and they are in their way.
So I'm going to pivot this because Barbara's question is a common question. How do I know when it's time to do something as serious as intentionally cause a heart attack or cut out a piece of my heart? When do I know it's time?
So if you have symptoms with your daily activities, then we know it is time. If the patient still is having doubt about how much limitation they have, we do what is called a cardiopulmonary exercise stress test, and we are able to compare their performance to a normal subject of their age and sex. And based on the results of that test as well, the recommendation can be made. Another tool we have in our hands is when we measure the pressures in the heart, in the right side, called the pulmonary artery pressures. By echocardiography, that gives us as well an insight. So we have several tools, including the symptoms, the stress test by exercise, and the pressures.
So I'm going to follow this up with some more conversation on the topic, and please all weigh in. I try to look at some of these decisions that people are struggling to make with a slightly different light. If there was another anatomical problem inhibiting the heart, the way that it functions, congenital defects come to mind. We correct them when we know they're wrong because we know long-term that's not good. That's not the way the pump's supposed to work. Why do we look at it different in HCM, that we wait till people feel bad enough?
I would say, oh, go ahead, Dr. Nagueh.
You go ahead, Dr. Buergler. I've spoken some, so let's the panel.
Oh, that's okay. Well, I mean, I would say that we look at it differently because first of all, we currently are unaware that there's any mortality benefit to doing the procedure. That's the first step. Secondly, there is a risk to doing something just as there's a risk to doing nothing. The risk isn't zero. Inducing a heart attack in somebody should be taken seriously. Going to the operating room should be taken seriously. Even if your operative mortality in Dr. Lawrie's hands is under 1%, and we have similar results with alcohol septal ablation, it's not zero. So if you look at yourself in the eye and say, hey, you look at yourself in the mirror and say, hey, this is really affecting my life, I'm willing to take a little under 1% chance that things could work out very badly for me. But I want to have a good quality of life because currently I can't do the things I want to do. I can't shop. I can't spend time with my kids. I can't go to their football games. I can't do the things I want to do. That's the time to get the procedure done. That's the way I would answer it.
And then I'm going to add the complication in there that HCM symptoms come on slowly over time, and not everybody recognizes how they feel as a symptom. It's just normal. I always get winded when I walk up the stairs. I always feel like I'm going to pass out after I lean over to pick something up. Squatting down, oh sure, that makes me feel terrible. We just accept it over time. So I'm watching Amy shake her head. Amy is not just a staff member here at the HCMA. She's a heart transplant patient with former HCM herself. So she's nodding, going, yep, that was me. I was kind of talking to you, Amy, but I didn't want to tell everybody. So I was in denial over my own symptoms until I got really bad. So I think the reality of having a really strict, really good conversation with a patient and saying, what do you think is normal? And finding out that line. And we all know the lies we tell ourselves that don't ever come out our mouth. We know what we're feeling. Sure. We don't want to have to meet surgeons and interventional cardiologists and people who do invasive things. We get it. It's stressful. But they're also kind, caring, compassionate individuals who want to help you feel better. Let them do their job. Okay, Barbara, I hope that answered your question. I think it was quite well answered. So let's see. Okay, Barbara, we're not going to go back and forth with what your doctor wrote in that. I can't do that. That's not appropriate. Anonymous, how do I know if my MRI study will be completely read correctly? Is there a published guideline protocol? Should I be asking? A, go to a center of excellence. B, go to a center of excellence. C, A and B. Anybody else have anything to say on that?
Absolutely, I cannot overemphasize that.
Yeah.
The reason there are called centers of excellence is because the different pieces that are needed to diagnose and treat the patient are there. A critical piece nowadays in the evaluation of patients with this disease is MRI. And the centers of excellence have enough experience with MRI in general, and specifically with hypertrophic cardiomyopathy. Yes, there are specific protocols that are done. Yes, there are critical pieces of information that should be included in the report. So my advice is, if you are told you need to get an MRI, ask about which center you will get it at and check on that site and find out if they are a center of excellence or not. And I cannot speak about all centers of excellence, but the majority of them have superb imaging properties or capabilities, I would add.
Yeah, I'd just like to reinforce that, Lisa. We get sent a number of patients, and they'll often bring a cardiac MRI that's been done in a department primarily run by radiologists who are looking at wrist and head injuries with the MRI, and then they do the odd cardiac MRI. That's really not what we're talking about. Cardiac MRI centers at the highest level are staffed by cardiologists. It's a part of the cardiology department. And it's like night and day. And we literally have people who call us from out of state, and we insist that if they're going to be worked up, they have to come to our MRI center or something equivalent to have their MRI, because a lot of the MRIs being done are really pretty much worthless, probably worse than worthless, because of their lack of details. You can, as Dr. Nagueh says, you can tell by reading the report, because they're often lacking important data. For example, the percentage of the ventricle involved with scarring is a critical measure of the state of the ventricle in terms of risk assessment. And you'd be surprised how few of these smaller centers MRIs have even evaluated that very critical parameter for us.
Amen. And it is a critical problem. It's not only a problem with MRI, it's a problem with echo. Community-based echoes are not the quality that they should be. We are working with some partners on some education modeling that will help improve echo quality at the community level and help them get referred upstream very quickly when LVH is notified or identified. And it looks like it could be in the realm of HCM. But imaging, I hate to tell everybody, is about $1 billion problem in the United States, because we're paying for things that aren't very good. And it's a lot of resources being spent on poor imaging. And there's a lot of effort that needs to be made to improve imaging, MRI and echo, community-based. And the readers, you don't know who's reading your reports all the time. If you go to a center of excellence, you know where they're being read. You know who the overreaders are. You know who's following that quality. If you go to your local cardiac hospital, because it's a good cardiac hospital, you have absolutely no idea in most cases who's reading, what their skill level is, what level of training that they have received, whether it was the minimal or the maximal. You have no idea what their level is. Center of excellence, center of excellence. I want to make a point in stating that the charge that the centers of excellence get that are associated with the HCMA is negligible. It is administrative costs. We don't make money on this, people. I know what people wonder, why are you so evangelical about this? Because I've seen what happens in the community, and we know what happens in a center of excellence. You want to be in a center of excellence care, if at all possible. And in today's world, if there's reasons and barriers for you getting there, financial, insurance, etc., telemedicine is available in many centers, including this one, where they can overread and they can help guide. They might not be able to do everything through telemedicine, but at least we can see if the quality of the images is adequate to get you the information you need, to get you the care that you need. I know I preach it all the time.
Well, we're lucky in our region, because we have, we probably train most of the cardiologists for one thing, but most of our cardiologists are busy cardiologists dealing with a lot of more common things, and they will come across, like every practice, some people with hokum. But these people are very knowledgeable. They pick up something that looks like hokum, or maybe it's hokum. Many of our hokums present with mitral valve because we have a very big interest in mitral valve therapies. And so they see mitral regurgitation, and really they know they don't want to start some big workup out in their office for a hokum patient. They want to send it down to Dr. Nagueh or Dr. Buergler, who will then take advantage of our fairly large resources in terms of echo and CAT scan and MRI and nuclear to work these people up. And it's not at all uncommon for the diagnosis they come in with, is, for example, simple mitral regurgitation to turn into a hokum patient when after we see them, and that's fine. But the patients need to be aware, once the word hokum is mentioned, and particularly if it's in the setting of mitral regurgitation, these are some of the more complex things to sort out. What the mechanism of the mitral regurgitation is it really just all related to hokum, or are there intrinsic structural abnormalities of the mitral valve that need to be dealt with? These are not things that people commonly encounter in their daily practices. And that's why we have centers that specialize in gathering in these patients so we can get expertise and retain people who have that expertise.
I know as a patient, I'd rather be one of several hundred than one of 10 in a practice with a disease like HCM. So I'm really glad to hear that your region is doing well with that referral pattern. And we definitely need to make that happen in more communities around the world. We have another question, an interesting one. Could metoprolol or Multac cause general muscle weakness, shakiness, or tremors, or loss of coordination? If so, I would like to discuss these side effects, but I'm also wondering what else might be going on here. So does somebody want to talk about side effects of metoprolol and Multac?
So want to separate the two. Metoprolol is different from Multac. Metoprolol is frequently used in patients with dynamic obstruction and sometimes patients without obstruction to slow the heart rate and lower pressures in the heart. Metoprolol does not cause a weak heart muscle. Metoprolol does not cause shakiness or irritability. On the contrary, this class of medicines is used to treat tremors. Now, Multac is a medicine used to treat atrial fibrillation, get a patient out of atrial fibrillation and prevent them from getting it again. It has its own set of side effects. It has a modest effect on blood pressure, bringing it down. It has a good effect of slowing the heart rate. That's why we use it. It should not cause by itself a weak heart muscle or heart failure. It is dangerous to give this drug to patients who have heart failure. It has what we call a black box warning. If a doctor prescribes it, he or she has to ascertain that this patient indeed does not have heart failure before they prescribe it. The more common side effects could be some coughing, GI symptoms, some skin changes, but typically not the drug itself causing the heart failure. And
So
I believe you should.
Let me just clarify this a little bit. They're not looking at heart muscle. They're talking about musculoskeletal, other muscle weakness. You're on mute.
Should not cause generalized muscle weakness. No. I think you should speak with your cardiologist who prescribed this medication. Let them examine you carefully, or your internist should examine you carefully, and there may be additional tests that are needed before attributing these side effects to the drug.
You have muscle weakness and you're on a statin, that would be a more common thing perhaps, although I certainly don't know the individual medications the patient's taking. Certainly review by the internist or the cardiologist would help solve the problem.
I'm going to go down the rabbit hole on this one just for a second. I would also ask if this individual's had genetic testing and knows the genetic variant that might be associated with their HCM, because some of the phenocopies for HCM can have muscle weakness associated with them. Not so much shakiness or tremors, but muscle weakness can be a sign of some of the more rare genetic disorders. So I would check all the boxes and try to figure out where the muscle weakness is coming from. It may have nothing to do with the HCM. They may be true and unrelated. The body is a complicated thing. Everything's not because of HCM. I have, if we want to go by commonality, knee surgery is a trigger for HCM because people get their first EKG then and they get diagnosed with HCM. But I don't think bad knees have anything to do with HCM. It's just a lot of us have bad knees. So
I think one thing that maybe perhaps our use of language is more precise than some of the patients. We do see patients who are really seeking surgery because they're on such gigantic doses of beta blockers that they're just exhausted. It's not so much their muscles are, if you tested their muscles, they could probably lift the same weight, but they're in a state of chronic fatigue just from the effect of such beta adrenergic blockade at the dose of 150 to 200 milligrams a day of a drug that's normally given at 25 to 50 milligrams for non-HOCM people. So some of these poor people are literally staggering around on these doses, and they finally decide, them and their families finally decide the quality of life is at the point where they've got to get off some of it, and they need it for their HOCM.
I think that is an excellent point as well. And I know a number of people who are on 150, 200 milligrams, and you wonder, how are you even talking to me? I'd be sleeping all day if I were you. And they're trying to function. So that becomes very difficult. There have been comments about altitude in HCM. Now, you're not exactly a high altitude area, but is there a problem with patients with HCM maybe not living in high altitude because you tend to acclimate to the level that you're at, but if you're traveling or vacationing to high altitudes, is there anything that can be concerning to an HCM patient?
If they have already pulmonary congestion, some degree of pulmonary congestion, going to a high altitude location can make them more symptomatic. At least early on, because of the lower oxygen levels in the blood and the less oxygen delivery to the tissue. As they get acclimatized, these symptoms may become less.
The other thing that can happen at altitude is a degree of altitude sickness, and supraventricular tachycardias can occur in healthy people when they go to altitude, including atrial fibrillation. And they just have to be careful that they don't have a risk of decompensation with a rapid heartbeat that they haven't had previously when they're at the high altitude. Not so much just the fact that the oxygen levels are a little low per bit, but that they actually may develop a touch of mountain sickness and decompensate more than a normal person would.
2001 Yellowstone altitude sickness.
Oh, wow.
Treated by a waitress at a diner who gave me 2 glasses of orange juice and told me to drink them all right then and there. It worked. I slept for 8 hours. I felt better. But my healthcare professional was the waitress at Denny's.
Did a good job.
She did. She's like, I know, I can see it all over you here. And she just brought them out. I'm not leaving until you drink them or I'm calling 911. Okay, we did it. It worked. Okay, back to Jamie's question that she so patiently asked a long time ago. She would like
just one other thing about altitude, which relates to the fact that you may actually have been helped by the orange juice, is the fact it's very easy to get dehydrated and loss of preload on the heart. Obviously, the people with HOCM are often somewhat more sensitive to their filling pressures in their circulation and their state of hydration, especially when they're traveling.
Exactly. Okay.
Hope she didn't serve you any coffee.
I wasn't drinking coffee at that point in my life. I didn't start drinking coffee until I was 40. And that was an HCM conference related thing too, but that's a whole other story. Okay. Jamie's question is about MRI. She has an ICD. I do not believe she has an abandoned lead. I think she just has a dual chamber pacer defib. And she'd really like to have an MRI because they identified some tricuspid valve flap and a small aneurysm in her ascending aorta earlier. Can she have another MRI now? Is it safe?
Yes. And as of last month, it's safe to have it with an abandoned lead. It was just a big study that came out. So our center is doing everybody now. MRI compatible and MRI non-compatible defibrillators and abandoned leads. There was, I think, a big study in JACC of several hundred people with abandoned leads who were studied, and there were no significant serious complications. A few people had warm leads with subcutaneous leads, but other than that, so as of now, our MRI center is accepting all these patients.
Well, we all just learned something really important tonight. I thought abandoned leads were going to be a forever bar, but no. Okay.
No, it's turned out okay. But the other thing is, it's we see a lot of people with defibrillators coming in for evaluation for HCMA and for other cardiac conditions, and they have to get the manufacturer's representative to go to the lab. They have to turn the device off. It's not just simply a matter of, you're not going to walk in and say, I need an MRI, and they'll just say, we'll take a seat and we'll put you in there. It's a little bit of organization to do it, but it can be done. And they also can't get a good evaluation of scar burden and the quality of the myocardium, because the leads will often interfere with the ability to observe the gadolinium because of the artifact from the leads. So you can get a lot of volume measurements like severity of MR and the quality of the ventricular function, but some of these finer details we sometimes look for, particularly in HCMA patients, are simply physically not detectable. They can put them in the scanner, but they can't get the views necessary to get that data.
So in Jamie's case, just looking at her comments, it appears that what they want to look at is the tricuspid valve and the ascending aorta.
There should be no problem.
Yes, these can be done by MRI, but also you can see the ascending aorta by CT. For example, you can look at the tricuspid valve with a lot of detail with echocardiography. So there are alternatives. It is not a must that the MRI should be done. And again, going to a center that has experience can make a big difference in what is done and how carefully it is done.
Jamie, thank you for asking that question, because I learned something incredibly important tonight, and now I got to go read that article in JACC, and we got to get a newsletter out on that. There's a lot of people who would really like to have MRIs and haven't been able to for these abandoned lead issues. So thank you so much for that. Okay, ladies and gentlemen, we're rounding up the night. If you have any last questions, you can ask them now. We're at this point going to wish our Facebook viewers a good evening, and we're going to stop streaming on Facebook. Facebook people, I will not be podcasting tomorrow, but you can go up the stream here and you can see the podcast with Marty Marin that was done earlier today. Pretend it's tomorrow. Okay, thank you, Facebook. And